following episode is brought to you by the American Urological Association. This episode features content from the AUA 2025 meeting in Las Vegas. For more information on how to claim CME credit for your participation or to view faculty disclosures, please visit the AUA University. This educational activity is supported by independent educational grants from Astellas, Janssen Biotech Inc., administered by Janssen Scientific Affairs LLC, Lantheus Medical Imaging, Novartis Pharmaceuticals Corporation, and Pfizer Inc.
Greetings all, 1:30 on my clock, so I'm going to go ahead and get started out of respect for everyone's time. My name is Mark Bierlin, one of the urologists from the University of North Carolina. For the agenda today, there's a couple of housekeeping items that I have to read verbatim. I'm going to do a quick introduction about the topic and who our speakers will be today, and then we'll go over each of the presentations for today. So to get started, housekeeping items. This course utilizes audience response questions. To participate, you'll need to scan the QR code located on handouts near the entrance to the meeting room or on the screen. The AUA 2025 annual meeting mobile app is available and free to download. When you download the app, you will be asked for a username and password. Course materials are available on the AUA 2025 website and mobile app. Use the email that you use to register. Your password is your AUA ID. You can find it on your registration badge. As part of its disclosure policy, the AUA determines whether disclosed relationships with ACCME-defined ineligible companies are relevant to the educational content of the CME session and mitigates any conflicts of interest prior to the session. The full disclosure policy and report of relevant financial relationships are posted on the AUA's annual meeting website, aua.org/annual meeting, and a link is posted on the mobile app. CME credit claim. Please ensure that you log in to the CME credit claim site and confirm this session has been added to your record. The link is posted in the mobile app and through QR codes in the meeting guide and signage. Please follow the instructions on the site to ensure you complete the entire claim process for all sessions as soon as possible and no later than December 31st. No credit will be available after this date. Please remember to silence your cell phone. No photos, video, or audio recordings are permitted. And those are the housekeeping items. So to get started, I'm just going to touch base briefly on this topic, introduce our speakers, and then we can do the pre-test kind of questions. So in terms of course objectives, I won't read them to you here, but we'll discuss a number of things in terms of molecular imaging in 4 different disease spaces. We'll focus on bladder, or I should say I'll introduce them in the order. We'll talk about prostate first today, then kidney, then testicular, and then bladder. We'll look at some of the emerging radio tracers, some of the performance characteristics currently as they stand in molecular imaging, and then perhaps some future opportunities to expand this topic. So historically, when we've talked about molecular imaging, most commonly patients have been staged locally, distant, or bone metastases through some type of conventional cross-sectional axial imaging, either CT or MRI, and really only those patients with some type of equivocal finding actually went forward and got some type of molecular imaging. But fast forward, this has actually been changed significantly, where really molecular imaging is now the primary modality for a number of disease spaces, where that is the preferred molecular imaging choice for local staging, distant staging, and bone staging, and a little bit of what we'll talk to today about even molecular imaging to monitor treatment response. So with that, I'll introduce our speakers today. Dr. Spencer Baer is from the University of California, San Francisco. He is a clinical radiologist. Mike Gorin is a faculty member at Mount Sinai in New York City, practicing urologist. He'll discuss kidney cancer, molecular imaging. Dr. Tracy Rose is my colleague at the University of North Carolina. She's a medical oncologist. I won't again bother to read everyone's full history. And again, my name is Mark Bierlin. I'm a urologist from the University of North Carolina. So at this point, I'll transition over to Dr. Baer. He will start with prostate, followed by Dr. Gordon for kidney, Dr. Rose for testicular cancer.
Good to see you, buddy. So thank you very much, and thank you everyone for being here, and thank you to the AUA for inviting me to give this talk. Yeah, the answer to this one's pretty much yes for most situations now. It's pretty fascinating that about 10 years ago, it'd be like, okay, we'd have to be like very defined, but it really has expanded in the last few years about molecular imaging and prostate cancer. It's been profoundly fascinating as a radiologist watching this change. So first off, my disclosures. So the goals of this is to highlight the clinical indications. We're just going to focus on PSMA PET. It has really taken over and moved out the other agents like choline and FACBC. I will reference them in some of the niche situations in which we utilize them at UCSF. We could review some potential pitfalls and things to think about that we always emphasize as radiologists, and something you should always be aware of is potential false positives for these examinations. And lastly, discuss about moving from just imaging over to therapy with PSMA-based therapy. So I always think this is a great illustration and an overview of all the different radiotracing targets that we have studied in PSMA, in prostate cancer. This is a review article done by Andre Wibner. For me as a nuclear medicine physician, the one that I use every day, day in, day out on multiple of our patients is FDG. This is the fluorodeoxyglucose. It's utilized in multiple malignancies, but we learned very early on, not so good for prostate cancer, unfortunately. Has some niche applications, but really not going to use it. That's why there's all this interest and all this research that went into exploring all these different targets. And really the story of this revolution started in 2012 with choline. That was introduced and really studied out of the Mayo Clinic. This got FDA approved in 2012. And I'll never forget this. I was a fellow back when this was approved. And I got calls the minute the FDA approval went out from our radiation oncologist and our urologist asking it to be done the next day. I had explained to him it's going to take a little bit of time to get this available, but it really pulled back the veil about showing to me how much need there was for molecular imaging in prostate cancer. The story continued with this compound, FACBC. What is FACBC? That's an amino acid. That's the AAT amino acid imaging agent that targets the L-leucine analog. But as that was being developed and finally getting FDA approved, studies started coming out with this compound, which has really taken over all of our molecular imaging in prostate cancer, PSMA. What is PSMA? It stands for prostate-specific membrane antigen. It targets the transmembrane glycoprotein in epithelial cells that is massively upregulated in prostate cancers. There are 3 FDA-approved compounds. There's the 2 that was FDA approved back in 2021, then there's a 3rd that was approved in 2023. In general, when you're reading these, we treat them all the same. There are subtle differences between them from a biodistribution, but in general, the statement from the SNMMI is you treat them all the same right now. Unlike the forebearers of this, with choline FACBC, we have an option to switch out the positron emitting agent and treating them with a beta emitter. We'll talk about that towards the end with the lutetium-based 617. So how does it compare? Why did it take over the world of nuclear medicine for prostate cancer? Well, let's look at the one that was approved before it, choline. Clearly outperformed, low PSA levels, less than 2. Every area, much better. What about fluciclovine, which came back 4 years afterwards? How did it perform? Much more wide-ranging PSA levels and biochemical recurrence. Outperformed it pretty much everywhere, but where? In the local recurrence. Why is that? Well, fluciclovine has to be imaged 4 minutes after injection because of the fact it doesn't bind to the tumor, it sort of sticks there and gets washed out. So the minute we inject, we have to image the patient, and that means we don't have any really urinary excretion. Really helps us from looking for pelvis. Just give you an idea of where we've come from the PSA detection level in terms of the detection of metastatic disease. Back when I was a resident of abdominal imaging and starting nuclear medicine back in 2010 to 2012, we had to rely on CT and bone scan. We had to wait for the PSA levels to get to 20 before we really detected being confident in systemic metastatic disease. Now, with choline that came along, that value dropped to a 20th of that with 1.16, and the story continued down, all the way down to PSMA down to about 0.2. So I've seen positive scans at 0.1. So really, the bar has significantly dropped, almost a hundredth of where we were before. So how do we prep these patients? Anybody who's ever ordered an FDG PET, you have to keep these patients NPO, not with PSMA. Come in, you can have had lunch, you can image on the scanner, no problem, right? Because there's no competitive analog to this. Only thing that they can take all their medications. The only thing we ask them to do is drink some water and then void before the examination. Why do we ask them to void? This all goes in the urine. Lots of radiopharmaceutical in the bladder makes it hard for detection of pelvic nodes, as well as local recurrent disease at the anastomosis. Normal biodistribution, lots of uptake in the lacrimal glands, salivary glands, liver, spleen, bowel. This can make it really challenging for evaluation of the upper abdomen and nodes up there. So sometimes that can be really tricky. Then physiologic excretion in the kidneys, ureters, and urinary bladder. And again, as a radiologist that reads these, I always have to fight what is ureter and what is a lymph node. So I always live on this MIP image, and I always do coronal and sagittal reformats, look for what's the difference between ureter and what is a pelvic lymph node. So finally, moving on to the clinical indications, really there's three main categories in which we'd use PSMA. There's the patient's pre-prostatectomy for high-risk disease. There's the biochemical recurrence, whether it's post-prostatectomy or post-radiation. And lastly is screening for treatment with lutetium-177 PSMA. So first off, the pre-prostatectomy and high-risk disease. A lot of our patients at UCSF, we're fortunate to have a PET-MR with them. If not, then they always get an MR before they get their PSMA PET. Why do we do an MR? Well, it helps us provide T-staging and accurate local assessment of disease, in particular, looking for extraprostatic extension and seminal vesicle invasion. And then we got the PSMA PET. Why? Well, great for improving nodal and metastatic disease. And then top of it, there's a lot of data that's supporting the fact that it's actually as good, if not at least complementary to the MR for detection of the primary. What about patients? We've only been talking about the high-risk disease. What about active surveillance? There's several ongoing trials that are looking at this cohort, and I think this one's going to be the next one to expand into in the near future. Why is that? Well, PSMA PET detected MR occult lesions in 61% of patients. And of those, 28% of them had a higher grade disease. And PSMA PET will detect increased risk stratification and detection of clinically significant disease. PSMA PET has about 90%, detects about 90% of clinically significant disease. So it's a real complement to MR in this patient cohort. So let's go through some examples. Here's a 72-year-old Gleason 4+4 prostate cancer, PSA elevated. These are the MRs that we always want as a radiologist, clearly defined tumor. This is a nice PIRADS 4 lesion, concomitant uptake on the PSMA PET. Nice thing about the PSMA PET, it gives us great assessment of systemic disease. So with this one, we're highly confident this is a local prostate cancer, no PSMA avid nodal or distant metastatic disease. So on top of being diagnostic, it's also prognostic. Why is that? Because negative lymph nodes, we see no lymph nodes on the PSMA PET, they have a higher likelihood of being disease-free, so having lower rate of biochemical recurrence. So I don't know why, although all my cases tend to be on the left side of the prostate. You'll see them, they're always going to be on the left. Here's a 60-year-old Gleason 4+5 disease, so high-risk disease, showing a PIRADS 4 lesion. Probably with a little extra capsular extension. You can see there's blurring of the extraprostatic fat. Matching uptake on the PSMA PET, you could see it would be very hard to look for extraprostatic extension in this area. Now this is where it got so striking for me as a radiologist. There is a metastatic lymph node in here. Can you see it now? It literally screams to you. And like one of the striking things for this when we were reading this is sometimes we don't even see the lymph node on anatomic imaging. We just feel like there's a little round dot. And it's probably referring to a lymph node because it's like sandwiched right behind, like right next to iliac vessels or right next to the psoas. We just have to be confident that is the location of the disease. To really see what that MR, you have to blow it up, and that's the tiny little lymph node. It's about 3 to 4 millimeters. As an abdominal imager, I would probably, on a good day, maybe say indeterminate. A lot of times we'd be like, it's probably just a benign lymph node. So it really helps us from detection. But how good is it? So how good have we finally reached that holy grail of detecting all sites of disease? Nope, bin sensitivity is still only 60%. We're not detecting those microscopic 1 to 2 to 3 cell nests of tumor. We're a lot better where we were, better than CT and MR. And what about if we add the multiparametric MR? Still better, right? So we're a lot better where we are. We haven't gotten 100%, but definitely a lot better than we used to be. Here's another example, 68-year-old, very elevated PSA, showing large bilateral tumors due to comorbidity and the volume of tumor. The patient was going to be treated with radiation to the prostate and bilateral sidewalls. But because of the high PSA, we went and got the PSMA PET MR. Something on this PSMA PET MR changed the patient's management. We can see that there's actually very intense uptake, bilateral disease. But then we saw this. What is that? That's a presacral lymph node. This was going to be outside of the field of view. So our radiation oncologist, this one, included that in the field of view. This underscored a finding from a study that was done by Grumeller et al. That showed PSMA PET MR in patients prior to definitive therapy changed it in about a third of the patients. A significant alteration in patient management. So I want to end the pre-prostatectomy group with this case just as a thing to always consider in the back of your mind. This was one of our early patients that we did. So we got the MR on this patient first, shows a Pyrides 4 lesion and then the anterior fibromuscular stromal tumor. So yes, when we got the PSMA PET MR, we're going to see an intensely avid tumor in the, wait a second. That uptake anteriorly is actually in the urinary bladder. We saw no uptake. I walked over and reviewed it with one of my colleagues, just making sure that I wasn't going crazy, and he agreed, yes, that's clearly a tumor. So we followed this one to surgery, and guess what the surgery showed? Which one's falsely negative? Was the PSMA PET falsely negative or the MR falsely positive? MR was right. This underscores the point that while vast majority of the clinically significant prostate cancers will have PSMA expression, not all of them will. So if it looks like and smells like cancer, don't be dissuaded by a negative PSMA PET. And we'll talk about other examples in which this is the case. So moving on to the biochemical recurrence groups, this one we do a ton of UCSF, and we do it very often longitudinally. Patients will go with definitive therapy, they'll come back and they'll be re-imaged again. Here's an example. Again, I told you, I don't know why my examples are all on the left side. What we're looking for in the prostates, MRs, we're looking for areas of abnormal enhancement. You can see this would be the one that we want to see as a radiologist, clearly area of abnormal enhancement, the left prostate bed. Here's the MR showing, here's the PSMA PET showing concordant uptake. This can be really helpful. Sometimes we look subtle areas, but we see this intense area. When we see matching, makes our confidence very high. But again, what is it very helpful in terms of looking for? Systemic disease. So something here really changed the patient management. Nothing in the retroperitoneum, nothing in the pelvis. Hard to see, but there's 2 subtle areas up in the thorax that on the fused PET MR images actually co-fused to the sternum and the spine. So the patient got directed radiation therapy by my radiation oncologist to those lesions. PSA went to non-detectable after for definitive therapy. So how often do PET CTs alter patient management? Well, one study showed it affected about 1 in 2. So about more than 50%. How did it alter patient management? Usually it just added an area that was going to be treated with radiation, found another site. Surgery, they could feel like to either treat the patient or they could expand the surgical resections. The big thing here I want to highlight is look how many patients got taken off that they had planned to doing systemic therapy. So punted it down farther down. So kept them off the ADT. Speaking of ADT, what does that do to our PSMA PETs? Well, it causes heterogeneous impact depending on the timing. So when we see it early, it causes this flare phenomenon. So we'll see increasing uptake. And then as the longer it's on it, drops off. The challenge here is that it's very heterogeneous. So we don't have the exact timing down yet. So by NCCN guidelines, it actually recommends that if you're going to order a PSMA PET on your patients that are going to go on ADT, make sure it's done before you initiate ADT. We've had a few patients that we've had a backlog of our PSMA PETs They get their ADT first. I'm staring at there going, oh no. Is this a negative scan or is this just a patient who's started getting response?
Has anybody looked at it as additive, like increase the sensitivity, scan?
Awesome question. The question is whether we'd use that as sort of using ADT, correct me if I'm wrong, using ADT to try and increase the sensitivity of the PET scan to initiate therapy. I'm not aware. Have any of you seen it?
Yeah, so actually Tom has a paper.
But he didn't do it as a bridge to treatment. He did it as the ADT and then he imaged the patients. He didn't do it as a bridge to therapy.
Oh, I thought that's what the question was.
No, he was asking if using it prior to initiation therapy for detection, correct?
Yeah, and increase your detection rate.
Yeah, Tom did it as, he did it in a patient and he imaged a bunch of patients. So he's referring to my colleague, Tom Hope, who did a study on this where he looked at, and that's where the data came for on the flare phenomenon, but never as doing, let's say, give the person ADT. Just redirect me if I'm wrong. Give ADT, wait 2 weeks, image them with PSMA, then use the directed radiation therapy that you're planning.
Yeah, see if you're capable.
I'm not aware of any study that's ever done that.
No one's done that.
Yeah. Interesting.
Let's do it.
Yeah.
But
I've actually discussed it with the radiation. They're like, well, if we're going to put them on AT, they're going to respond. Let's just stop. That's my understanding with when we've talked about it. I think it'd be very interesting to see whether you're missing. We could talk more afterwards, but great question. So this is one of the things that we do for a lot of our patients, why it's so great having the PET-MR. We always have the post-contrast. This is an area of focal uptake right along the urethra, so you're stuck there this was read before we read out the MR, so we read our MRs separately from the PSMA, and the nuclear medicine's like, it's just physiologic uptake in the urethra. Well, when we got the post-contrast MR, we see that there's two urethras. No, the anterior one's the urethra, the posterior one was the area of local recurrence. So we can confidently say focal area of recurrence, no evidence of metastatic disease. So here's a PSMA PET. No eye test here, this was negative. This person had 2 sequential negative scans. PSA was continuously going up. We look back at their staging PSMA PET, showed very little uptake on their PSMA staging PET. So we said, well, let's try something else. We tried FACBC, and when we looked at the fused FACBC exam, we actually saw this. So this was a lymph node, and we look back at the PSMA, there's like a little bit of warmness there, probably same level. You're not going to call that on the PSMA. So this was an example of FACBC positive, PSMA negative node. So again, this hallmark said not all of them are expressors, are intensely expressors. So what is the significance? So what happens if you get a PSMA negative PET? What do you do? Well, there's a study that looked at 101 patients with negative PSMA PET in the setting of biochemical recurrence. They ended up treating these patients with either radiation plus AT, or they surveilled them. Their conclusion was you can treat them with radiation. Just the most likely area of recurrence was the pelvis. That was the recommendation based upon their paper. So now I'm going to talk about some of those pitfalls I was referring to. Here's a patient with elevated PSA after prostatectomy. We talked about tiny little lymph nodes, and we're always confident those are lymph nodes. Well, I'm always very careful in specific locations. This is one of them. This is focal uptake right anterior to the crus of the diaphragm. Either crus, this is a classic location for ganglion. This is a celiac ganglion. It's not a lymph node. They're going to have intense uptake on PSMA PETs. I don't know exact mechanism why some patients there are, some patients are not. But you always have to be careful. Cervical, you can see in the cervical, first patient I read had actually intense uptake. I'm like, is this a lung cancer? And then I had to Google to make sure that I wasn't going crazy, and that's actually where the cervical ganglion is. Then there's the celiac, and these are especially tricky. This presacral ganglion. If I see low level, multiple of them, I'm counting 8 lymph nodes. I'm going to call them, they all have low level. I let them go. These are just presacral lymph nodes. Another big pitfall is this. Anytime you see uptake in your patient's chest wall, I look very closely at the anatomic imaging. Why is that? Rib fractures. Inflammatory processes can have low-level PSMA uptake, and this is just an acute rib fracture. In fact, rib lesions are relatively common. They're usually benign on their own and low-level uptake, and I tend to ignore them if they're not intensely avid or getting more intense in the follow-up if there is one. There's been lots of studies that have looked at solitary bone lesions. Of indeterminate bone lesions, a majority of them are indeterminate on follow-up. Most are unclear, but only a small percentage end up being malignant. So I treat these very, very carefully. I don't say like, oh yes, definitively, because there's lots of benign things kind of uptake in the bone. So another pitfall case that you always have to consider in the back of your mind in your patients, this. So a patient with polystotic metastatic disease, and we saw this intense uptake in the neck. Fused PET MR image, it turns out to be the thyroid gland. PSMA PET metastasis to the thyroid gland. Well, we recommended a thyroid ultrasound. This ended up being papillary thyroid cancer. So there's been studies that looked at this. About a third of them end up being papillary thyroid cancer. So I always recommend thyroid ultrasound for potential biopsy. What's interesting about this, we also saw this. Mildly avid PSMA left cervical lymph node. So we're torn whether this was a Vercoe's node from the prostate cancer or the thyroid cancer. They biopsied this. And the biopsy was inconclusive, so they surgically resected, and it came back as benign inflammatory lymph node. So 3 different processes in the same patients. The question then becomes, is PSMA really that specific? Sort of misnomer with the utilization of S in there. So it's really, really sensitive, but not 100% specific. Seen in lots of malignant lesions and benign lesions. So my caveat with this, if it doesn't look classic for prostate cancer or prostate cancer metastasis, always consider a synchronous process. So lastly, moving on to the last one that we do, we use it for screening prior to treatment with lutetium-177 PSMA. What is lutetium-177 PSMA therapy? We've kicked off the positron emitter, so our imaging agent, moved it on to a therapeutic beta emitter with lutetium. These are patients that have been treated with, that are at metastatic castrate-resistant prostate cancer. This is new this year. They had been treated with multiple different lines of therapy in the past. Now it's moved down and expanded now to patients after failure of ADT. And I've treated a couple patients in the last couple of months with this. Dose is 200 millicuries regardless of the size, always 200 millicuries. We can treat up to about 6 cycles of therapies. It's about 6 weeks apart. How are the outcomes? Well, there's been several studies at this. The big one that led to the FDA approval is the VISION trial, which showed that adding this therapy on top of standard of care had increased prolonged progression-free survival and overall survival compared to standard of care. That's why it got FDA approved in 2022. So I want to end this one with an example of a patient that one of my colleagues saw in Dr. Hope. This is his clinic that he has for treatment. He has a radionucleotide therapy clinic at UCSF. This is one of the patients that I managed on this day when he came in. 60-year-old being treated for almost 15 years for prostate cancer. Unfortunately, this is a lot of our PSMA PETs showing polyostotic metastatic disease, elevated PSA of 904. We always draw PSA right prior to therapy. So on the day of their infusion, we draw a PSA level to see the kinetics. So you can see the PSA levels were continuing to go up even between the PET and the therapy. But just after just 1 cycle, you can see all the matching uptake on the PSMA to the PSMA therapeutic. Significant response. 3 cycles later, went to 100th of the PSA. So went from 1,000 down to 88. Some future directions. Again, I sort of alluded to it. With active surveillance, this is being actively looked at right now. There's been several studies. Why is that? Because there's been shown, as I referred to before, that PSMA detects about 90% of clinically significant prostate cancer in particular. It detects a lot of lesions that are not seen on MRI. Lastly, for treatment response, this is one that we're trying to determine where it fits in the paradigm, right? So patients who've got polyostotic metastatic disease being treated with different lines of therapy, how do we use it in the therapy? As we talked about it, there's sort of, have heterogeneous response. Several trials are looking about it. Like I use FDG PET all the time for lymphoma. It's got a profound impact on patient management. The hope is that we can figure out exactly where to place PSMA into helping determine how well and what the prognostic is of the response. So key takeaways here. PSMA PET, 3 primary indications: pre-treatment, biochemical recurrence, prior to therapy as screening. PSMA PET is exceptionally sensitive with significant impact on patients with even low. Still haven't gotten that 0 bar, but the recommendation is about 0.2 for detection levels. PSMA uptake is not as specific as the name would imply. Always be very careful. Think about other processes, either benign or malignant. Watch out for those false positives. If someone by accident calls that celiac ganglion positive or those rib lesions is positive, have them go double check, make sure they're really confident what they're calling as positive. Conversely, not all prostate cancers are PSMA positive. Vast majority of them, vast majority of them, but not all of them are. And lastly, we can treat what we see. So if they're positive on the PSMA screening, we can treat them with a therapeutic. Thank you very much. Happy to take some questions now. If not, if you have any questions, my email, feel free to come up, send me an email. Always happy to discuss.
Yes. Do you have any experience of a rising PSA still below 0.2, but consistently rising, at a reasonable rate, but still patients anxious about the results? What this means?
So as I was saying, the question is whether we have a reasonable amount of experience, like patients developing PSMA-avid metastasis between, let's say, scan 1 and scan 2, but their PSA is still less than 0.2. Let's say it was like 0.1 and 0.18. I don't think I have anecdotally a lot of experience of like all of a sudden seeing a nodal site or seeing a new site of disease. I don't know about you all, whether you have any experience with that. Like,
At the beginning, we imaged a few folks just to figure out like how low we could go.
Yeah.
Never saw anything that low.
Yeah, no, not that low, but I mean like in temporal change, like at which point we see a disease. Usually it starts going from, I've seen patients image at 0.1, then 0.3, and 0.4, and still not see the site.
Yeah, absolutely. Yeah.
And then, so I don't know, and then so sometimes they'll prophylactically just do radiation-directed therapy.
I mean, the thing is that, it's commonly misunderstood that you want to find something on these scans. You actually don't want to find something.
Yeah.
If you have a patient who you clinically believe has recurrent disease, if they have nothing on scan and you administer salvage therapy, they far and away do better than the patient who you believe has recurrent disease and you see something on the scan. And that's been shown a handful of times in the literature.
Yeah, it's the tip of the iceberg effect, I like to call that, right? Where let's say you see a bone met, there's probably a lot of other bone mets that are harboring other places. You can stem the tide of disease, but it usually means that it's already out of the box. That's my experience from when I look in our tumor boards. Any questions online or?
No questions online, but maybe I'll throw two out at you. For
Hit me.
us institutions that don't have the luxury of doing a PET MR,
Yep.
have to do a PET CT instead, can we anticipate similar level of performance characteristics?
I think so, right? As long as you have that MR and the post-contrast MR and a good quality MR, you just have to make sure the radiologist compares them.
Yep.
And I think looking at them, and then like the big things that are most helpful for me, those wispy areas of enhancement with the brachytherapy seeds when I'm just like an eye poke. I took the case out there, but those used to languish on our list because the radiologists are like, oh, no, right? But they can make us highly confident, and it really helps us read them out.
The other question I had is now that there's several FDA-approved PSMA PET agents, and we're more commonly following men longitudinally with multiple scans, do they have to get the same agent every scan, or what happens if they don't get the same PSMA PET radiotracer for all their subsequent scans?
So there's data to support that, like gallium versus F18. F18 tends to give you a little bit more false positive bone lesions because there's a dissociation of the F18 from the compound. Then you get sort of like a sodium fluoride scan. I would say it's always preferential to try and keep the same agent because there's a little bit of variance between those two compounds. But I would say that from our global overview, if you have no option, I think it should have very minimal impact.
How do you do it at your institution? Do you schedule them on the day where you've offering agent number one that you gave them the first time, or you only do one agent?
We predominantly just do one agent. We have a contract with the vendor, and that's the one we predominantly use. Yeah. But yeah, we had a carryover between two compounds. But yeah, we predominantly have used one. I think some places predominantly just have a contract where they just get one shipment from one PET vendor.
Yeah. Wonderful. Thank you very much. Any other questions? If not, we'll move on to our next topic. Mike, you are up. Dr. Gorn will speak on molecular imaging and kidney cancer.
Okay.
I think you can drive, Mike, and actually if you exit out of Spencer's.
Yeah, how do we switch the slide?
Try X.
I think you could.
Yeah.
And then
Oh, okay, I got you. Okay. Okay, is the timer going to go on? Mark, you tell.
as needed. I think we're okay.
You think we're okay? Okay, good. Alrighty, so I'm going to tackle the topic of molecular imaging for renal masses. And the topic specifically that I want to dive into is the concept of using molecular imaging to histologically classify a small renal mass. This is sort of different than Spencer's talk in that I'm not going to focus on staging imaging or search for sites of disease in patients with metastatic disease. That's sort of a whole nother talk, and quite frankly, not as interesting of a story in renal cell carcinoma. And that tends to be because contrast-enhanced CT and MRI already do a really fantastic job of being able to pick up those sites of disease, and we make some gains, but very little through the use of molecular imaging. But I think that this is a slightly more interesting use for it. So my disclosure is relevant to this talk. I do have a patent on a few compounds that target CA9. Okay, so I think we all are aware that there's an ever-increasing incidence of the indeterminate small renal mass. This is because patients are increasingly getting cross-sectional imaging for a variety of different medical indications. Thankfully, though, not all small renal masses are necessarily a cancer or necessarily the most common form of cancer, kidney cancer, that being the clear cell subtype. We do have benign renal masses, as I'm sure you're all already aware, including the AML and the most common form of benign renal mass being the oncocytoma. However, when you look at a CT scan, you cannot differentiate between, or mostly cannot differentiate between these histologies. And so when faced with the question of a small renal mass, oftentimes patients undergo treatment for the assumption that it's cancer. Even within the different RCC histologies, there's varying prognosis associated with them. We know that patients who have a low-grade papillary RCC do far and away better than those patients with, say, an unclassified RCC. And so when we look at the guidelines from the NCCN, there's a variety of different management strategies that patients with a small renal mass have open to them. And this ranges everything from radical removal of the kidney to active surveillance. So how does one decide which of these treatment paradigms is most appropriate for a patient? Well, the guidelines cite to the concept of using a biopsy to help you guide this decision. Firstly, is this benign or malignant? And then if it is malignant, does it have features that, say, make it more amenable to active surveillance and treatment? There are, however, limitations of renal mass biopsy. Firstly, there's associated pain and discomfort on the part of the patient. They have to miss a day of work and so forth. There's a fairly large non-diagnostic rate. The current two meta-analyses that looked at this in most detail place it between 10 and 20%. There's a major complication rate of about 1%, and that is from gross hematuria that patients either require a transfusion for or a catheter or something like that. And when we think about this non-diagnostic rate of 10 to 20%, that's among all tumors that have even undergone biopsy. How many times have you looked at a scan and said, I don't think that tumor's in a location where it's safe to perform the biopsy? Well, I would consider those to actually be non-diagnostic because no biopsy was performed. In addition to that, there are issues with being able to determine the grade of a tumor, and there's this concept of molecular heterogeneity. So there's all sorts of issues with using renal mass biopsy in this manner. So many in the field have asked, can we use molecular imaging as a means of differentiating between these various renal mass histologies? And it turns out you can. There are two forms of molecular imaging that could be done to achieve this goal. The first being the girentuximab PET-CT, not yet FDA approved, but on the precipice of being approved. And then we have technetium-99 labeled sestamibi, which is a SPECT imaging compound, and this could be used as well. So I'm going to go through sort of the various components of this table to compare and contrast these two imaging agents for you. So first we'll start with girentuximab. So girentuximab targets the molecule carbonic anhydrase 9. So normally when cells are exposed to hypoxic conditions, cellular machinery results in the upregulation of CA9. However, in cases of clear cell RCC, where probably 90, if not 95% of cases have loss of the VHL protein, you get sort of constituent translocation of HIF1 alpha to the cell nucleus, prompting the upregulation of CA9. So a hallmark of clear cell RCC then is this abundant upregulation of the CA9 protein on the cell surface. And that's what girentuximab targets, this protein here. And you can see it's pretty darn specific for clear cell RCC. Here you can see the papillary subtype of RCC does not take up the antibody used for this staining. So over the years, there have been a variety of different forms of the girentuximab antibody, which have been used for both diagnostic and therapeutic purposes. Here's an image from a study that was published in the Journal of Clinical Oncology using an I-124 labeled version of the antibody. You can see a clear cell RCC lights up beautifully with the radiotracer, whereas a benign oncocytoma does not. So if faced with this patient, you could make a very clear treatment decision for what to do with them without having to do a biopsy or simply guess. The I-124 antibody was used in this trial called the REDEC study, which is now more than 10 years old. It was published in Journal of Clinical Oncology, and it compared the I-124 labeled antibody to contrast-enhanced CT scan, and were able to show an overall accuracy of 86% versus 68% with contrast-enhanced CT. And where the gains were really made is in terms of specificity for the radiotracer, which then led to rather high improvements in both the positive and negative predictive value of the radiotracer. So since that early phase study, Tilex Pharmaceuticals has put together a phase 3 study to confirm the results of the REDEC trial. And this was called the Zircon trial. It was reported out in, I guess, the last 6 months or so in Lancet Oncology. The reason why a second trial was done is actually in federal law. It states that you have to have trials with an S demonstrating the efficacy and safety of any drug or compound. And so typically we have 2 studies, as silly as that may seem to have to repeat it twice. And in the Zircon trial, what they did is they swapped out that I-124 for zirconium-89, and this is the format that you're going to probably see it approved for use in clinical practice. And the reason for that is because what they found is that the zircon-89 leads to this charge capture mechanism, which allows for improved signal-to-noise ratio, so you get even better images. So again, the Zircon trial reported out in Lancet Oncology, and similar design to the REDEC trial, where patients were imaged with the PET-CT scan and then underwent partial radical nephrectomy. The histology served as the truth standard. They were able to show a sensitivity of 86%, specificity of the same, meeting its key endpoint. There are, however, limitations of girentuximab. So it's an antibody-based radiotracer. So this means it has to circulate for a very, very long time before it has an opportunity to bind to its target. It's not like the PSMA radiotracers that Spencer was talking about. Those are smaller molecules that have very, very high binding coefficients. Antibodies bind much, much more weakly. And so it's a pretty inconvenient test actually to administer. You inject the patient with the antibody, and then they come back 3 to 5 days later to get on the PET scan. As opposed to PSMA, we inject them, and then about an hour later, they're on the scanner. There's high cost to PET in general. Okay, I mean, it's not that expensive, but it is a limitation of it when we compare it to sestamibia, at least. There is limited availability of PET scanners in certain parts of the world. And probably, the biggest issue is the availability is limited by a pretty small distribution network of folks who are capable of producing the antibody, as well as the zirconium-89 radiotracer. In terms of cost, once it's approved, it's going to be on patent for more than 10 years. So, you could imagine this is going to be really expensive to actually buy the radio tracer, and it's going to be expensive for a really long time. I would say, though, the most important limitation is it only tells you clear cell RCC from all other histologies. So if you have a positive test, you could move forward with confidence, right? If you have a negative test, you're still not quite sure what to do with the patient because it could be a benign lesion, but it could also be a malignant lesion, and that malignant lesion could be something very dangerous, like an unclassified or a translocation RCC, and so forth. So positive test is helpful, negative test is not. So my group, formerly when I was at Hopkins with my research partner, Dr. Steve Rowe, who's now at UNC, we asked the question of, can we use molecular imaging to differentiate between these modalities? And can we do so in a way that addresses some of the issues with girentuximab? So the agent that we have focused on is technetium-99, technetium-99 labeled Sestamebe, which is a mitochondrial imaging agent that's been in clinical use for how many decades now, Spencer, would you say?
3, I think, or 4.
It's a very old compound, and it's a SPECT imaging agent, so it's a lot more inexpensive to produce. No one owns a patent on it, and so forth. And the way Sestamebe works is it's this large lipophilic cation. It passively diffuses into the cell, and then it travels across the mitochondrial membrane, where the molecule then becomes stuck because of these charge differential. So any cell type that has lots of mitochondria are going to glow with this imaging agent, and I'm going to show you in just a moment why we felt that this then made sense for imaging small renal masses. So where is Sestamebe normally used? It's most commonly used as a cardiac imaging agent or as an agent for imaging parathyroid adenomas. The reason why is because the oxyphilic cell of the parathyroid adenoma is chock full of mitochondria, so it makes it so that you could very easily find these parathyroid adenomas and then subsequently go in and perform surgery to remove them. So we knew that oncocytomas, these tumors arise because they have mutations in some of the genes responsible for the electron transport chain. And so as a result of that, these tumors, although benign, pump out tons of mitochondria into their cytoplasm. That's why they're so pink or eosinophilic underneath the microscope. In contrast, clear cell RCC, when you look at it after H&E staining, it's not pink at all, and that's because the cytoplasm is basically devoid of any mitochondria at all, and rather just is filled with these lipid droplets. And so we hypothesized then that if you give patients this mitochondrial imaging agent, you may be able to selectively identify the benign renal masses, and anything that lit up on the scan, you could then avoid treatment in, and anything that was cold, you could then treat. Turns out we weren't the first to have this idea. These folks at Dartmouth had this idea in 1996. Back then, though, they weren't using SPECT-CT, they were using planar imaging. I would say, planar imaging, it kind of almost looks like a Rorschach drawing. It's really, really hard to make out what you're looking at, but they actually were able to demonstrate it. They had these 6 patients in the study, and lo and behold, they found the oncocytoma had a no defect in the renal parenchyma lighting up with the radio tracer, whereas these other entities actually showed a defect. So here you could see with the planar scintigraphy, this oncocytoma lighting up. That was what it looked like in 1996. Nowadays, though, we have fused SPECT-CT, and we could beautifully see these renal masses. So this has been studied not only by our group, but by others throughout the world. This was the first phase 2 study that we did of it, an image and resect trial, much like the REDECT and the Zircon trials, where we had 50 patients undergo imaging and then undergo partial radical nephrectomy. And we found a sensitivity of 87.5% for being able to detect either oncocytomas or these what no longer actually are classified as hybrid oncocytic chromophobe tumors, are now called something entirely different. But at the time, they were referred to as this. Nowadays, we refer to these as oncocytic RCCs, which is thought of as, while it is malignant, its behavior is virtually benign. And in terms of false positives, we saw only about a 5% false positive rate, and it turned out that the false positives were both chromophobe RCCs. So since the time of this first publication back in 2016, like I said, our work has been repeated by others throughout the world. And there was just last year in European Urology a systematic review published on the topic. And the systematic review showed that, yes, there is some variance in the literature. The performance characteristics of the scan, while in some studies was equivalent to what we had found, some found it less. But on average, the numbers are essentially what I had quoted to you before, about 85% sensitive and about 90+% specific. However, things have evolved a little bit since the early days of our work here, and that is that some of the RCC entities are no longer referred to by the same names that they once were. We've also learned a lot more in that there is a pretty high percentage of chromophobe RCCs that have eosinophilic enough cytoplasm that they will light up with the scan. We've also come to learn that AMLs tend to light up with the scan. And this is that new entity I'm referring to, the low-grade oncocytic renal tumor, I think is what the WHO refers to it now. These are these sort of like, some of them were considered unclassified tumors. Sometimes these were tumors that people would, in the past, refer to as the hybrid oncocytic chromophobe tumors. Some of these perhaps were mislabeled as papillaries, as chromophobes. We do have better diagnostic criteria now, and we actually have a grouping for them. And again, they behave in a pretty benign or indolent fashion. So the way that we currently think about the scan is that if it's hot, it's either an oncocytoma or one of these things. So it's either benign or behaves very benign. And if it's cold, then it's a clear cell RCC or one of the other potentially aggressive forms of kidney cancer. So to date, all the work that's been done is either signal center or retrospective in nature. There is a group in the UK that has a prospective study that's ongoing. It's called the Multi-MEBI study. We don't really have any results from it yet beyond, I think they published the results of like the first 20 patients that contain various sort of like diagnostic yield aspects of it, so they knew what their cut points were for calling positive and negative. But the true results of the study haven't been published yet. So what we've come to learn is that if you use SESTA-MEBI SPECT CT for this purpose, you could actually save, for the healthcare system, a ton of money, as opposed to performing a biopsy, sending everyone to surgery, or just sending everyone to surgery, that it's really quite cost effective to use SESTA-MEBI because you spare a lot of patients unnecessary surgery, which comes with tremendous cost. And these are what those cost data, basically look like. If we compared a partial nephrectomy as sort of the as the base, I believe the number is about $14,000 are saved as a result of implementing the scan. And if you do an approach where you use SESTA-MEBI plus biopsy, meaning that anything that's hot you treat as positive, anything that's cold you then biopsy and then manage appropriately based on the biopsy, you could see that very little, if any, malignant tumors are missed in the process. So in conclusion, the indeterminate small renal mass is a diverse clinical entity. It includes a number of different benign and malignant tumor types. Patients presenting with an indeterminate renal mass should be managed using a risk-adapted approach that takes into account their histology. Not all patients should go to surgery. Not all patients go for active surveillance. You should know what the tumor is to be able to select the appropriate management strategy. Renal mass aids with this, but there are issues which I mentioned before, namely the high non-diagnostic rate and the fact that not all tumors can be biopsied. Molecular imaging, in my view, certainly offers a promising non-invasive means of being able to differentiate between these tumors. We've got SESTA-MEBI, like I said, a positive test is an oncocytoma or an oncocytic renal neoplasm. And then we also have girentuximab, which helps you identify clear cell RCC apart from the others. SESTA-MEBI can be used readily now. It's clinically available, it's off patent, it's cheap, it's easy to do. Girentuximab is on the precipice of FDA approval. And once it's approved, you'll probably be hearing from TLX about how to order and use in your clinical practice. But do consider the caveats that I've mentioned here. In particular, the fact that a positive scan with a girentuximab tells you that it's RCC, but a negative scan, you still have the question of benign versus malignant. And that's it.
Questions from the audience or any questions online? I've tried to adopt Sestamib intermittently in my practice, and we've had the luxury of now having Steve Rowe in our institution who's had tremendous experience with it. But I've kind of hinted this before. Any advice to the audience or to ourselves that are newly adopters to this technology in terms of learning the curve of interpreting the image to say whether it's hot or cold?
Yeah, I mean, I think what we've really come to learn is that it's all about the appearance of the tumor relative to the renal parenchyma, more so than simply being hot or cold. Because you could have a tumor, say, that's like, only 60% of background or 70% of background. That's actually a lot of uptake relative to the background. Relative to what the kidney is, when you compare it to like a clear cell, which is entirely cold and maybe like 0% of the background. So it's important to realize that these are not going to look like fireballs relative to the kidney, because the kidney is, so incredibly avid for the radio tracer. I think it's critically important to partner with your nuclear medicine physician, radiologist when getting this program going. You're going to need, it's got a learning curve to it. You're going to need to see a lot of scans, and probably the best way to do it is to image patients and take them to the operating room, and then you kind of are basically doing your own little calibration experiment there to know what an oncocytoma looks like and what a clear cell looks like. SPECT, and Spencer could probably speak to this better than I can. SPECT is, there's a lot of differences, I think, between the equipment, right? The settings on the equipment and so forth, and the settings, say, that we used back when we were at Hopkins or you're using at UNC now, may not apply necessarily to that third institution that's going to implement it. So there is a little bit of playing around and tweaking that has to be done to get this thing to work appropriately for you.
Great. All good advice. We'll switch gears. Dr. Rose will cover testis cancer molecular imaging next.
Oh, yeah? Yeah. How's it been performing? What's that?
Okay, thank you very much. Yes, so I'm going to talk about using PET in the diagnosis and management of germ cell tumors and testis cancer. So as everybody here probably knows, germ cell tumors are highly curable cancers. And so one thing that needs to be considered when we're talking about how to stage and how to work up these patients is really long-term morbidity of whatever we do, including overtreatment. And I think that's a theme in part of this talk. Overtreatment is a real risk for highly curable cancers who have expected life expectancy in the decades. It's also critically important to differentiate patients that need additional therapy with those who are already cured. So in this talk, we'll go over a role of PET for initial staging of germ cell tumors, then its main role as evaluation of post-chemotherapy residual disease, then prediction of early treatment response, which is an emerging theme, and use of PET in germ cell tumors, and then novel tracers and future directions in the future. So basically, if we're talking about initial staging, PET-CT use for initial staging of any germ cell tumor is recommended against in guidelines. It includes European guidelines and NCCN guidelines. And that's based off, a number of studies actually have looked at the utility of PET in staging. This is one of them, published actually a couple decades ago now, that looked at clinical stage 1 and 2 non-seminoma germ cell tumors and looked at FDG PET prior to primary RPL&D. So the classical imaging and then surgery study to look for sensitivity and specificity. I'll note that this study, because the landscape was changing in how we treat non-seminomatous germ cell tumors, was under accrued. They actually stopped the study early because of poor accrual, with a lot of surveillance of stage 1 patients evolving during this time. And 19 patients out of the 72 that accrued actually had pathologic nodal involvement. But they initially had their primary endpoint of negative predictive value and positive predictive value of greater than 90%, which they did not reach, so it was a negative study. And if you look out the data on this and you compare conventional CT scans with PET, you can see that it improves sensitivity and specificity a little bit over conventional CT, and combined, if you get both a conventional contrast enhanced CT and PET CT, you can boost sensitivity and specificity a little bit, but really, it has not been considered sort of worth the extra cost and trouble of the PET, because the negative predictive value is still only 80%. And a lot of this we think of is actually because if you're looking at non-seminomas, PET cannot pick up some of the teratoma, some of the reasons we do RPL&Ds, and so it's considered that these numbers are just not good enough, and so PET doesn't get you over a threshold where you might be able to avoid primary RPL&D in these patients or further adjuvant treatment. There was another staging study that looked at sort of the role of PET in stage 1 seminomas. We use PET a little bit more frequently in seminoma, and so there were several cohorts more recently of this semi-TEP trial. The first cohort looked at a number of patients with stage 1 seminoma to see if we could utilize FDG PET. You could see that out of 166 patients that went on this study, 96% of them had just a negative PET at first. So really unlikely to detect any occult disease that wasn't picked up on contrast enhanced CT, and only 6 patients, so 4% of the population, had a positive PET. And then if you look at and you follow all these patients over time, actually 22 patients ended up having a relapse with a negative PET. And so you can see that still, even utilizing PET, 15% of your patients are going to relapse, which is similar to many of the long-term follow-up studies of solely contrast enhanced CT. So, the interpretation of this study really is that getting a PET up front for stage 1 seminoma may pick up a rare patient with positive lymph nodes, but does not detect the majority of patients that are going to relapse in the future, and is not part of guidelines for staging. So really the role of PET in germ cell tumors falls in how to handle patients post-chemotherapy. And so this is actually one of my patients who the scan on the left is their pre-chemotherapy scan, and scan on the right is post-chemotherapy. And so, sometimes we use PET in this setting to help differentiate who needs more treatment. So the first thing to say is that this is really primarily done in seminoma. So for that same reasons that we talked about, PET tends to be a little bit more useful in seminoma because we don't have the same risk of not picking up teratoma or other components. And so in seminoma, we've learned that actually the first thing to look at, even before you're necessarily considering a PET, is the size of the residual mass. And we learned early, kind of a few decades ago, that really size of residual mass post-chemotherapy for seminomas predicts the likelihood of viable seminoma pretty well. And so if you look across studies, most of the early studies that were presented in sort of the 1990s or so show that the chance of residual seminoma, if your tumor is less than 3 centimeters, is quite low. You can see there's actually 0 cases in these 3 studies. There's a few studies that show some cases, so it's not actually 0. But the chance of viable disease is quite low if your tumor is less than 3 centimeters. So there's really no role for PET for residual disease less than 3 centimeters. And the controversy and the discussion really comes in whether we should get PETs in patients with residual disease greater than 3 centimeters. And you can see if you have measured greater than 3 centimeters, the risk of relapse or viable seminoma goes up a lot. So between 13 and 50% in these studies, which is kind of true in modern times as well. So bottom line here, if you have a residual mass less than 3 centimeters, there's no role for PET. After that, currently FDG avidity is what we use to sort of guess at viable seminoma after chemotherapy. However, it's certainly not perfect. And, seminomas come with this very inflammatory desmoplastic reaction, and you can get false positive PETs, FDG PETs. Similarly, this causes very demanding surgeries. Post-chemotherapy RPL&D for a residual seminoma greater than 3 centimeters is not typically an easy surgery. It comes with a lot of morbidity, potentially associated nephrectomies, et cetera, et cetera. And so really post-chemotherapy surgery for seminoma is pretty rare these days, and really should only be done with surgeons that have high volumes in a multidisciplinary team. The recommendations in the guidelines to consider PET in this setting, so patients with a 3 centimeter or greater mass after chemotherapy, really come from this SEMPET study where they took 51 patients with advanced seminoma who had post-chemotherapy PET, and they found a pretty good sensitivity and specificity for FDG PET. You can see 100% specific, 80% sensitive with 100% positive predictive value and 96 negative predictive value, which is really improved numbers compared to conventional CT, because many large tumors are not viable in seminoma. And so you can see, all of the lesions that were PET positive, and 35 of 37 lesions that were less than 3 centimeter were correctly predicted by FDG PET in this setting. And I think one point to really stress here is the timing of the PET. And so this study looked at sort of time from end of chemotherapy to PET, and then several other studies have validated it. But really the PET needs to be done well after chemotherapy with sort of a cutoff of 6 weeks. That's been validated in multiple studies now. And so if you look at sort of 100 and something PETs from 19 different centers, you could see that the positivity rate ends up being about 1 in 4, and these studies really showed that waiting at least 6 weeks is necessary to prevent the false positives that you get immediately after chemotherapy. And again, that's from this very inflammatory desmoplastic reaction that we see. I'll just note, I'm a medical oncologist, so sometimes the end of chemotherapy is a little bit vague. So I just want to note that this is truly, 6 weeks after the last day of the last cycle of chemotherapy, which may be different than the last dose of chemotherapy. So, if you're getting EP chemotherapy, you get treated days 1 through 5. And the way they defined this is actually, day 21 of that cycle was considered the last day, even though that was a good 2.5 weeks after that last dose of chemotherapy. So just make sure it's a good 6 weeks after, the final cycle of chemotherapy ends to really improve on positive predictive value. And so you can see here, before 6 weeks, your positive predictive value is, all lesions of only 25% or 31%, so your accuracy is in the 70s. But if you wait until the correct time point after chemotherapy, you can improve that significantly, with a positive predictive value of 78% for lesions greater than 3 centimeters and an accuracy of 91%, and pretty good negative predictive value. So, after the SEMPET trial, this is when guidelines sort of started to adopt, we should be using PET post-chemotherapy in lesions greater than 3 centimeters for seminoma patients to help us decide whether to take them to surgery or not for RPL&D. Even though it is in guidelines, it's still not entirely clear that, if we can detect the node, that RPL&D is necessarily a treatment that will prevent relapse and long-term outcomes. And I think that this paper kind of threw the paradigm a little bit into question in how we use it. And so this study published at JCO in 2018 actually looked at patients with positive PET scans post-chemotherapy with greater than 3 centimeter seminomas and sort of looked at what happened to them, right? And so they went through, it was 90 patients eventually got included in the analysis. And for one reason or another, some patients ended up getting repeat imaging some got primary resection, some got a biopsy, and then some got radiotherapy after chemotherapy. And you can see only about a third of patients ended up getting primary resection, 29% based off their positive PET. And of those, 5 or 20% of those actually had seminoma in the specimen, one of whom relapsed, so you didn't sort of cure that one patient. Two of them, so you can see 21 of them had no seminoma in the specimen. And then of those that had repeat imaging, only 11 ended up relapsing, and so 22% of that. And so, it's not clear that actually doing a primary resection in the setting of a positive PET scan actually prevents relapse. That if you add up all the numbers on this chart and look at what the actual positive predictive value was for a positive PET in this patient population, it comes out to 23%, right? And so you would be doing surgery on, nearly 80% of patients with a very morbid surgery who weren't going to end up relapsing. And so, I think this has actually added in repeating imaging into the guidelines and made a lot of us question how much we're actually doing good to RPL&D, even patients with equivocal or positive PET scans post-chemotherapy. I'll note that all but one patient in this cohort that relapsed were successfully treated with high-dose chemo or salvage chemotherapy. And so even in the setting of a patient that you don't do a RPL&D on and has a relapse, almost all of them are salvageable with further chemotherapy. And so this is the NCCN guidelines. You can see, for seminoma, primary chemotherapy, if you have a residual mass less than 3 centimeters, you're done, go on to surveillance. If you have a residual mass greater than 3 centimeters, you either can do surveillance or consider PET, right? So it's very kind of wishy-washy here, even in the guidelines. And then if the PET is negative, surveillance. If it's indeterminate, repeat it. They recommend 6 to 8 weeks here in guidelines. And if it's positive, do resection or biopsy. I'll just say that in that, I didn't highlight it, but then in that paper I just showed you, they actually biopsied 10 patients with the seminoma. None of the biopsies were positive. And so you can see, biopsy is an option, although not entirely specific. It's very hard to biopsy these patients because there's a lot of negative biopsies, even in the setting of viable cancer. And then, surveillance after that. So even guidelines are, they don't come down that strong for use of PET because a lot of times we can salvage these patients. So consider PET. If it's indeterminate, consider repeating it. And really there's a role to watch these patients as well. EAU guidelines sort of match this. They say when a post-chemotherapy mass remains positive with FDG PET with no growth, repeat it should be performed 6 weeks later. A recent publication, that's the paper I just showed you, shows a low positive predictive value for tumors and residual lesions greater than 3 centimeters after chemotherapy and metastatic seminoma. Therefore, caution is recommended with FDG PET as a single parameter to drive clinical decisions in a persistent mass. And if you look at this paper out of the Indiana group, they looked at, if I take patients to surgery and they do an RPL&D and they have pure seminoma detected at the time of surgery, how did they do? And so this looked at 36 patients that had viable disease at the time of this post-chemotherapy surgery. And only 25% of them at 5 years remained cancer-free. So you're still, many of these patients are going to relapse. And so you're wondering how many patients are we actually curing with surgery off a PET scan. In particular, seminomas, they wrote, was particularly resistant to local control with many retroperitoneal relapses. And so this is a kind of a follow-up from the Indiana group, actually looking at if you wait and don't take these patients to surgery and they progress with clear progression on imaging or increase in tumor markers, et cetera, how do patients do? And this is 79 patients at Indiana treated with high-dose chemo, so it's, a very intense chemotherapy with stem cell rescue that relapse in their seminoma after first-line chemotherapy. Their 2-year progression-free survival was 90%, which is quite a bit higher than the sort of RPL&D group. So that being said, systemic chemo is quite toxic, but the cancer control here is really impressive. So in summary, given the low rate of residual tumors in lesions less than 3 centimeters, FDG PET is not recommended, but you can consider it for tumors greater than 3 centimeters. If it's negative, you're done, very reassuring, there's no viable germ cell tumors. If it's positive, consider repeating in 6 weeks to 3 months. Think hard about post-chemotherapy surgery and RPLND, and then consider salvage chemo at unequivocal progression or if morbidity of surgery is estimated to be high. This is a patient, as an example, that had seminoma, got BEP, actually progressed, got TIP salvage, and then you can see that scan on the right, still has some residual, but that would be a difficult surgery. It's a very classic scan where you can't really even necessarily measure the mass because it is so infiltrative, difficult to see. And this is not I know I'm sitting next to a radiology colleague here, but it's actually very hard. There's these algorithms that say positive and negative in them, but when you're actually sitting in a tumor board for a seminoma patient after chemotherapy, they don't really say positive or negative. They say things like, it's less avid, but still avid above mediastinal blood pool. And you're sitting there saying, well, is that positive or negative? I need to know. And they say, well, we can't really say those words, right? And so there's all these sort of equivocal reads on PETs after chemotherapy. And I've really learned over time, unless they say that's a blaring hot, definitely tumor, I watch these patients now. And I watched this patient, and he's still doing great. These are scans later. So in non-seminoma, similar to the staging data, PET is really only marginally better than conventional imaging for assessment of residual disease. If you look at this study, you get your specificity and sensitivity up a few percentage points, as well as your positive and negative predictive value. But really, these numbers are not good enough to not take a patient to RPLND. The reason we do RPLND in many of these patients is in case there's teratomatous component or other viable tumor, it's truly curative, and so these negative predictive values cannot rule that out. PET is unable to differentiate teratoma versus scar necrosis. There's a couple studies looking at this theory of kinetic rate, but it's really not validated. And so really all guidelines say there's no role for PET in the management of non-seminomatous germ cell tumor. I'll admit, as a PET-happy medical oncologist like most of us, we do it sometimes. So if you have a patient who's sort of relapsed several times and you're considering taking someone to surgery for residual disease, but you're not sure if it's right, et cetera, there's the cases, the certain subtypes like chorios, et cetera, that may be very PET avid. It can be used at times, but really in routine management of non-seminomatous germ cell tumor, PET really has no role. The evolving world, and this is really still investigational, is looking at PET for germ cell tumors in determination of treatment response. And so this was essentially an early study that showed that you can use PET, much like we use tumor markers and avidity on PET to look for response. And so, they did a PET before chemo, they treated with several cycles of chemotherapy and did a PET afterwards. And you can see that if you look at sort of PET changes, it improves on conventional imaging whether or not there's a residual viable tumor, not too dissimilar to how we use tumor markers. And so they essentially have designed several studies to look at, well, if PET can predict treatment response, can we use PET to de-escalate therapy, right? So if we do an early PET for someone on chemotherapy, can we then back off on their chemotherapy if they've had a beautiful response? And so this is one study that looked at it, did an early PET very early in chemotherapy. If you had negative complete metabolic response, so a truly negative PET, then you only gave 2 cycles versus 3 cycles. And based off this earlier study is the semi-TEP study, this is the second cohort other than the staging cohort, which I showed you earlier, that took metastatic seminoma, treated patients with EP times 2, so typically we'd give times 4, then did a PET. Patients that were positive got standard EP times 4. Patients that were negative after 2 cycles actually then switched to 1 cycle of carboplatin to try to reduce long-term cisplatin toxicity. And so they enrolled 99 patients, did PETs on 98. Out of those 98, 71 had a negative PET and got to receive 1 cycle of carbo instead of the last 2 of EP chemotherapy. The 27 who had a positive PET got 2 more cycles of EP. And if you look at progression-free survival for the patients that got EP plus carboplatin versus EP, they're basically identical with really good numbers of 3-year PFS of 90% for both. And you can see the neuropathy and the hearing loss or tinnitus was much reduced in the patients that got carboplatin. So there's an emerging role for PET potentially to de-escalate therapy. It's a little hard to say if those were the better prognosis patients and we gave them less chemo, like should their curve actually look better than the other group if they had a better prognosis and the less chemo puts it on top of each other? There's no way to know. So because of that, this is really still investigational. I'll say there's also really not, as it is hard for our radiologists to tell us if a PET's positive or negative, and they are commonly wishy-washy after chemotherapy. Same here, a validated metabolic response criteria has really not been developed for seminoma. And so this is really investigational at this time. The last part I'll just note is that several tracers have been actually pick up testicular cancer sometime. And so for example, the lutetium-177 PSMA can actually pick up a germ cell tumor. They actually tried to treat the patient with it, or PSMA PET picks up a germ cell tumor. They actually tried to treat this patient with lutetium-177 PSMA. It didn't work in this paper, but there's a theory there. And also, choline, F18 choline has picked up testicular seminoma in a prostate cancer patient, et cetera. There's been some thought of trying to develop tracers that can help differentiate necrosis from teratoma, one of the limitations of FDG PET. This is probably not the winner here. They, did this study looking at F18 fluciclovine, which really showed poor sensitivity and specificity for telling the difference. But there's lots of interest in newer PET tracers. Probably the future, though, is going to be microRNAs. The PET not having the greatest performance characteristics may very well be supplanted by microRNA detection for telling residual seminoma. So you can see that it does predict sort of progression-free survival, overall survival in seminoma. So in conclusion, there's currently no role for PET in non-seminoma germ cell tumor. FDG avidity has a high negative predictive value for post-chemotherapy residual seminoma. Management of FDG avid residual seminoma greater than 3 centimeters is nuanced, and RPLND and surveillance are both options. And then PET may be used to predict early treatment response and de-escalate chemo, but this remains investigational at this time.
Any questions from the audience or online? You can also circle back at the end of the presentation if additional ones come up.
Every time I watch you give that talk, I feel like I've been fed a lie.
Lastly, we'll touch base on
Not by-
bladder cancer.
I mean, you're uncovering the truth. Yeah.
So my disclosures are listed here, and then in terms of what we'll touch base on in this bladder cancer lecture, a little bit, or actually a fair amount, I'm looking at FDG performance in terms of PET scanning for bladder cancer. We'll touch a little bit on choline and acetate, and then a tiny bit on bone scanning. We'll look at the assessment of residual tumor after we do a TURBT, and then using PET scanning in the setting of primary tumor, lymph node, and bone metastases. We'll spend a little bit of time looking at a couple examples on neoadjuvant chemotherapy response, immunotracers, and then what do the guidelines actually have to say about when we should using FDG PET in the setting of bladder cancer, and what does the future hold in terms of artificial intelligence. So in terms of bladder cancer, which radiotracer do we use and why? Well, vastly FDG CT PET is used in the setting of bladder cancer for a whole bunch of reasons. It's widely available. We understand its performance characteristics. It has a high sensitivity for detecting osteolytic lesions, but there are some disadvantages of this radiotracer as listed here. It does have some inflammatory process lesions, so it becomes a little bit challenging after a patient just had a recent TURBT for a big bladder tumor, and then a week later they get an FDG PET. There could be some inflammatory response. Typically, we haven't been using a whole lot of choline or acetate radiotracers in the setting of bladder cancer, largely because of the limitation they demand an on-site cyclotron. So even though we have a cyclotron at our institution and it's across essentially the street from our cancer hospital, I can't recall one time in almost the last decade where anyone's ever got a C11 radiotracer, even though we have the cyclotron. So in terms of bone imaging, typically bone scans have been the workhorse, and they still continue to be that because they're widely available, they're cheap, and we understand their performance characteristics. Sodium fluoride PET bone scanning, PET has fallen out of favor for a whole bunch of reasons, but largely that CMS has said they're no longer should be utilized in this space. So looking at I keep referring to PSMA PET after so many discussions. FDG PET in the setting of bladder cancer. Really, one of the main limitations of looking at primary tumor staging for FDG PET is it's excreted in the urinary system, so it pools in the bladder. You can see the imaging on the right. There's that large tumor on the left-hand side of the bladder. But if you try to take a look at that post FDG injection, really you can't make heads or tails of what's going on in their bladder. So there's been a number of protocols to try to address this issue, specifically some type of forced diuretic, or either filling patients retrograde and emptying their bladder to get a better look at what is actually going on in their bladder. One of the protocols you can see here that's been published, the patients get administration of the FDG radiotracer. They drink significant amounts of water, and they either void by themselves or they give in some form of Lasix and voiding, or actually a catheter has been inserted, they've been irrigated, and then the radiotracer comes out, and then they get scanned, an early scan and delayed scan to kind of get a better assessment of actually residual tumor within their bladder. Here's a couple examples of that actually happening. This is a standard FDG PET about 60 minutes post-injection, and you can see here someone who's had some Lasix, drank a bunch of water, and then urinated. You can see that there's actually residual tumor there that's largely obscured on that top picture when the bladder is full of radiotracer. And then they get their chemotherapy, they get a repeat scan, and again, tough to see if there's any residual disease in their bladder, but again, forced excretion, form of Lasix and drinking water, you can see there's still residual disease in the bladder. So ways of kind of addressing the limitations of primary staging. There's been a couple of groups that looked at the assessment of residual tumor after TURBT, and this is one of the groups that did that. They grabbed just less than 80 patients. All those patients got an FDG PET CT 1 month after their initial TURBT. This protocol included the delayed diuretics, so they voided afterwards in order to try to see if they could see any more tumor. They went on to get another TURBT 2 weeks after that. And you can see here 35% of their patients had benign disease, 65% showed malignant, but essentially looked at the standard uptake value and to try to assess whether there was still residual disease in their bladder, with the ultimate goal of, if we can predict there's no more disease in their bladder, perhaps they could forego repeated TURBTs. And you could see here, as the SUV mean and max rose, that was associated with residual cancer in their TURBT specimen, as well as thickness of their bladder. They could risk stratify their patients in terms of low risk, moderate risk, in high risk, and then further kind of determine whether those patients in that low risk category could forego another repeat TURBT and all the potential complications that may come with that. So to switch gears a little bit, you can see here on this kind of busy slide, the vast majority of studies have been published in the setting of primary tumors. They typically have a low volume cohorts. There's different reference standards and a wide variety of sensitivity, specificity, as well as predictive values and accuracy. And as a result, really, there's been not a wide adoption of using an FDG radiotracer as primary tumor staging in bladder cancer. There has, however, been a somewhat wider adoption of using MR, and I know MR is not a molecular imaging agent, but I think at least needs to be listed in this context, and that the MRI vesicle imaging reporting and data system has been well validated now across the globe, essentially showing that this is a pretty good tool in terms of determining staging for local bladder cancer. So something that perhaps will be adopted much wider in the next coming years. Switching gears a little bit in terms of PET imaging for regional and distant staging. When we look at lymph nodes, we've compared CT PET versus MR PET versus FDG PET. And you can see here that this is a summary of a meta-analysis that was done using the standard criteria of either 8 or 10 millimeters as a suspicious node. And generally speaking, on average, you know, the sensitivity is fairly comparable between CT, MR, and FDG PET, and as well as the specificity is often overlapping in these three different imaging modalities. Looking at lymph node staging across the literature, again, there's different imaging modalities, including FDG, as well as some culling agents. The pathology reference is pretty wide and heterogeneous. Typically, these studies have not been very large, and again, that's reflected in their wide sensitivity, specificity, and predictive values. But really, is there a way that we can add benefit to lymph node staging by using FDG PET instead of CT alone? Well, there's a number of groups that looked at this. There's one group here you can see that took 103 patients who were all had high-risk muscle-invasive bladder cancer and who were all candidates for cystectomy. They all got a standard IV contrasted axial CT scan, and then they got also an FDG PET CT, and they looked at that PET CT and they compared it to their standard axial imaging and said, you know, is there differences in these different molecular or these two imaging types, and how did that manage or impact management? And you can see here that the CT PET showed metastatic disease in 47% of patients that were not actually seen on their conventional imaging, and this altered treatment in over 0.25% of their patients. 16 had their cystectomy canceled, 12 had their neoadjuvant chemotherapy extended, and then 3 patients actually had delayed treatment because they had a false positive FDG PET. Next, this is one of the largest studies published in the literature. It came out in the other year in European Urology Oncology from Germany. It was a retrospective study of just over 700 patients, but all of these patients got both a standard axial IV contrasted CT as well as an FDG PET, and you can see here the clinical stage changed in over a quarter of these patients. Largely, these are patients who are upstage. There was more disease found on the FDG PET than there was on the conventional CT scan. But in terms of treatment change, you can see the local treatment was changed in 20%, neoadjuvant chemo was changed in about 12%. Overall, as a whole, about 16% of patients had their management strategy changed based on the findings that were found on an FDG CT PET. So this was an interesting comment just made the other year. There's a study that was published in the British Journal, you can see it titled here, and that Sam Chang, who many of you know from Vanderbilt, who is the editor of the Urological Review Survey in the Journal of Urology, who writes specifically on bladder cancer, addressed this issue of should we be getting an FDG PET scan in these patients. And you can see here, as he wrote, this is verbatim, do I routinely order FDG PET scans when assessing patients with invasive bladder cancer? At this point, I do not. Improving imaging accuracy for patients with possible advanced urothelial cancer is important, and perhaps other ways to assess, such as biomarkers like circulating DNA, will ultimately play a more influential role in management direction. So one of the experts in our field highlighting here that he does not routinely get FDG PETs in terms of bladder cancer staging. Is a PET MR any better than CT in terms of primary tumor staging or lymph node staging? Well, there's not a whole lot of data in the literature. Looking at primary tumor staging, there's really been only 2 small studies, and you can see, generally speaking, their sensitivity, specificity, and accuracy is pretty similar between a FDG and a CT. And then looking at the MRI and the CT in terms of lymph nodes, one of the study didn't have any lymph nodes that were positive on radical cystectomy. So again, it made these numbers a little bit skewed, but generally speaking, it looks like a PET MR is not any better. So we do know that, multiple series may change guidelines, but does a handful of single institutions actually change our management? Probably not, but there is a multi-center randomized controlled trial that is ongoing in Canada. They're specifically addressing this question regarding the clinical value of an FDG PET over CT alone. I email them actually each year. We teach this course, and I ask them for an update, and this is no offense to their group, but this is typically the auto reply that I get. We're expecting to have outcomes in the next year. I haven't seen their paper published yet, but I'll get to some data that they did present in abstract in ASCO in 2023. So other radio tracers, you can see on the left, one of the main limitations of that FDG radio tracer is it pools in the urinary bladder, making not only the bladder hard to assess, but sometimes lymph nodes around the bladder hard to assess. Well, acetate doesn't have that problem. It's not excreted in the urinary system, and as a result, you can get a much better view of the urinary bladder. You can see here the performance characteristics of both C11 acetate and choline in terms of their sensitivity and specificity. Typically, again, like we've highlighted, probably in the same realm of FDG PET, but largely without an on-site cyclotron. These are pretty hard to adopt into clinical practice. So is there a role for PET scanning in terms of assessing neoadjuvant chemotherapy? Several groups have looked at this. It looks like they have slightly better performance characteristics than a standard IV contrasted axial imaging. You can see here in one study, at least, they have a fairly high percentage of identifying patients who responded to neoadjuvant chemotherapy in terms of complete response and overall response. And then you can see that sensitivity was a little bit better than standard CT, but the specificity was comparable. This was the study from actual Canada that's running that prospective trial, and they looked at specifically FDG imaging in response to cisplatin-based neoadjuvant chemotherapy. They had 291 patients so far enrolled in their study, of which 46 participated in this sub-study, which was only those patients that got neoadjuvant chemotherapy. They saw that the FDG PET could not quite predict relapse-free survival. You can see the p-value here, 0.054, but it was significant for predicting overall survival in this small cohort. So hopefully they're working towards those numbers, and when I email them next year, they'll say, lo and behold, here's our publication. Other groups have looked at assessing neoadjuvant chemotherapy response, and they've kind of given this algorithm as a possible way we can adopt this in the clinical practice. There's one group that has given 2 cycles of chemotherapy, and then they get patients in FDG PET, and essentially what they're looking at is a 50% reduction in their standard uptake value to see if these patients have been downstaged to less than T2. And their kind of thought process is, if there's no response on neoadjuvant chemo, probably no role in giving them more chemotherapy, and this is the subgroup that should go straight on to cystectomy. In those patients that do appear to be responding, they could continue to get their chemotherapy and then ultimately move on to surgery. So switching gears a little bit in terms of bone scanning, I only spend 1 minute on this slide. Typically, I think it was 2018, CMS said that sodium fluoride PET is no longer really part of the care pathway in determining bone lesions. As a result, it's largely fallen out of favor. And typically, if there is a suspicious bone lesion, that's assessed either on bone scan or some other type of imaging. But sodium fluoride PET, even though the performance characteristics are better, are largely fallen out of favor. So some of the questions that we're currently dealing with in the era of immunotherapy: how do we predict which patients will respond to some type of immunotherapy? our current approaches are really imperfect, and that results in a significant percentage of patients who don't really derive any clinical benefit and are exposed to immune-related adverse events. So it'd be great if we could identify these patients up front or early so they can avoid unnecessary treatment along with their attendant risks. And can we do that through some type of PET imaging? And there's been at least a couple of studies looking at, for example, zirconium-89 atezolizumab labeled PET imaging that predicted response to treatment. So I think this will be one area that is coming down the pipeline in terms of future molecular imaging agents. The other future agent that is probably here now is fibroblast activated protein. Dr. Baer's group from San Francisco actually has just started a clinical trial with this agent that we are also participating in. But there is some small studies that show that this agent probably outperforms FDG PET, at least in a couple of small studies. You can see here on the one on the left, 26% of patients with positive lesions that were missed on standard CT imaging. So it looks like this imaging radio tracer probably outperforms CT. A little bit further characteristics that these two had suspicious pulmonary nodules and pelvic lymph nodes on CT that were ruled out for malignancy by this new radio tracer. And then the study on the right, again, awful small, only 8 patients, but it's to start head-to-head comparing fibroblast activation protein to FDG PET. And there's some characteristics that show how this radio tracer can pick up additional lesions that may be missed on FDG PET. So with that in mind, what do the guidelines actually tell us about when we should be using an FDG PET radio tracer? Well, in the setting of non-muscle invasive bladder cancer, there is no role. We should not be getting any FDG PET in these patients. But for those with muscle invasive disease in the pre-treatment space, the guidelines are a little bit opaque. You can see 3 different guideline groups here. The NCCN suggests that you can get one if it's not been already performed and there's some suspiciousness for metastatic disease. And then since there's no IV contrasted, dye in this type of imaging, it should not be used for defining anatomy alone. The American College of Radiology says, there appears to be some improved data that says this may help detect nodal disease. However, it's not widely adopted. And the appropriate use criteria says this may be appropriate. So still a bit of a gray area in terms of guideline endorsement for this space. ESMO came out with their statement, and essentially FDG PET CT said that may aid in the detection of lymph node and distant metastases, but no clear consensus was reached. American Urologic Association, also not a clear guideline endorsement. They say that defining the role of PET imaging and the best PET imaging agent, as well as the investigation and validation of other novel technology, are deemed a high priority, but they don't have any endorsement of getting FDG PET in terms of bladder cancer staging. So what do we do with patients post-treatment? Well, again, guidelines are fairly gray in that. A National Comprehensive Cancer says only if your metastatic disease is suspected can you get one of these. American College of Radiology may be used to resolve equivocal findings identified on other imaging tests. So again, probably not a first-line imaging modality in the post-treatment space. And then the appropriate use criteria says typically this is not an appropriate use for this imaging modality. So then that brings up the question, well, how pragmatically can we use this imaging test in the real world? Well, at least in my clinical practice, I think there's probably 5 areas that I use it in. First, indeterminate lymph nodes or bone lesions on cross-sectional axial imaging. I think this is a reasonable test to get. Patients who can't get IV contrasted axial imaging for either having some allergy or their GFR is not great. I think this is a reasonable place to get in these patients. Suspected clinical T3 disease, hydronephrosis, and perhaps an indeterminate lymph node may be a reasonable space to get an FDG PET. And then high-risk histology, any other variant histology, plasmacytoid, micropapillary, small cell, and neuroendocrine features are probably reasonable to get a PET imaging in the setting of bladder cancer. So lastly, in the era of evolving artificial intelligence, will artificial intelligence help us kind of define findings on molecular imaging. There's been a couple of studies looking at machine learning in PET, and it looks like this is all promising. However, I think there's a lot farther we can go with this. There's been some reporting of CT and PET MR looking at predicting depth of invasion of the primary bladder tumor, grade, local, and systemic staging, and then some stuff in terms of treatment response. But ultimately, I think this is all coming down the pipeline, and we'll probably hear from this in the next couple of years. So with that in mind, you can see here that FDG PET has been around for 20, 25 years, and it'll probably stay around, but there's some new players in the field, specifically immunotherapy-linked PET agents, FAP, and then artificial intelligence for the future. So to wrap up, increasing evidence supports the use of FDG PET in the staging and the management of muscle-invasive bladder cancer. However, there's really no utility in getting it in a non-muscle invasive patient. Guidelines endorse its use in select cases. Emphasizing appropriate selection is really imperative, and then emerging radiotracers may play a future role in assessing response to immunotherapy. So with that, I'm happy to take any questions, and I'm just going to pop up this last slide. There were a couple of other questions online, and I think Dr. Barra might have addressed them, but I'll read them out in case anyone didn't see them. Regarding his prostate talk, someone asked, what is the lowest threshold for PSMA PET after biochemical recurrence, such as ultrasensitive PSA of 0.05 to 0.1? Do you ever wait for PSMA to hit 0.2? I think well, you can probably reply. I don't need to read your response.
Yeah, I mean, basically it's at the discretion of the treating physician. Like we've done plenty of them at 0.1. If it's non-detectable and then it becomes detectable, we'll do it. You don't just sit there and wait for it to drip up to 0.2. But it's always important to convey to the patient that it may not, this may just be not enough tumor cells to be seen on the imaging. So.
Great, thank you. So with that, thank you much. Enjoy the rest of your meeting.